Hello, and thank you for joining today's webinar. Dr. Nicoletta Machin will now begin the program.
Good afternoon, everyone, and welcome to today's program, a case conversation on recombinant von Willebrand factor in tranexamic acid for heavy menstrual bleeding in patients with mild and moderate von Willebrand disease in the USA. My name is Nicoletta Machin, and I'm an adult hematologist at the University of Pittsburgh Medical Center and the Hemophilia Center of Western Pennsylvania. I have a research interest in von Willebrand disease and its impact on women's health, and I'm excited to share with you one of our recent publications. I'm joined today by colleague and co-author Dr. Margaret Ragni. She serves as the medical director at the Hemophilia Center of Western Pennsylvania and is a professor of medicine at the University of Pittsburgh. We are honored to have her join us today with her wealth of knowledge and experience in clinical trials related to hemophilia and von Willebrand disease. We have been invited to speak with you all today by the Foundation for Women and Girls with Blood Disorders. The VWD mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every stage of life. With this, SWGBD aims to provide education to healthcare professionals on medical consequences and unique issues for women and girls with blood disorders. Since its inception, the foundation has focused on and realized its vision through these objectives that you can see displayed. So here's some housekeeping. To ensure best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with myself and Dr. Ragni at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen. We will address them during the Q&A session at the end of today's presentation. The next few slides detail our accreditation process in support of improving patient care. This activity has been planned and implemented by SignMed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided and follow-up email will be sent to attendees explaining how to obtain 1 hour of CME CE credit for the program after its conclusion. This activity is being provided independent of industry support. The learning objectives for this program are to identify unmet needs for women with heavy menstrual bleeding, describe the scope of associated morbidity of HMB, list current approaches to HMB and drawbacks of each, review key points for a balanced discussion with patients, and consider potential future studies to address HMB. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose. Speakers with financial relationships to disclose are noted here. All attendees will receive an email an hour after the program's conclusion with evaluation and this link to claim your 1 credit hour. The accreditation overview is also available as a handout. Before we begin our presentation, we would like to do a quick poll to see how many people are joining us today and with others, and to assess your current knowledge of the topic. Please take a moment to answer the poll questions on your screen. Answers are not going to be shared right now, but we'll get back to you at the end of the presentation. Please share with us how many are joining in the room today. What is the first line of therapy by hematologists for HMB? So please select one: tranexamic acid, progesterone IUD, or oral contraceptive pill. What proportion of HMB patients have iron deficiency anemia? So please select one of these percentages: 20%, 40%, 60%, or 80%. How long should oral iron be used before considering it a failure? So one of these time frames: 1 month, 2 months, 3 months, or 4 months. How did tranexamic acid, TXA, and recombinant von Willebrand factor compare in the VWD MIN trial? So please select one. Either both TXA and RVWF reduced HMB by PVAC, TXA but not RVWF reduced HMB to normal, PVAC less than 100, RVWF but not TXA reduced HMB to normal. Both TXA and RVWF reduced HMB to normal, a PVAC of less than 100. Great, thank you all for your participation. We'll ask these questions again and share the correct answers at the end of the presentation. Now I'm going to turn the slides over to Dr. Ragni for our presentation.
Good afternoon. I hope my slides are going to turn wonderful. Well, it's wonderful to be here to talk with you today. We're going to tell you about our study. Let me just go back. The recombinant von Willebrand factor and tranexamic acid for heavy menstrual bleeding in patients with mild and moderate von Willebrand disease in the USA. This is the VWD MIN trial. It's a phase 3 open label randomized crossover trial we were able to conduct with the help of NIH and Takeda providing the study drug. So by way of background, von Willebrand disease is the most common inherited bleeding disorder, and it's characterized by deficient or defective von Willebrand factor and mucosal bleeding. As many as 80% have heavy menstrual bleeding, which we actually noted in our first study over 25 years ago, but most were diagnosed significantly later than the first year of that symptom. In fact, it was 15 years later on average that they were diagnosed back then. I'm glad things have improved. But it's a pathologic state defined by excess menses over 80 cc's per cycle. HMB affects quality of life with iron deficiency and up to 80%, cognitive defects, and psychological stress. And in up to 30%, standard drugs such as DDAVP, hormones, and tranexamic acid are poorly tolerated or ineffective in heavy menstrual bleeding. And for this reason, the lack of effective therapy for HMB is considered a major unmet healthcare need. Unfortunately, few data exist on recombinant von Willebrand factor, and its well-recognized prolonged half-life, offering the potential for a single dose treatment for HMB per cycle. So we undertook a prospective multi-center randomized controlled trial in which we compared 2 cycles of recombinant von Willebrand factor followed by 2 cycles of tranexamic acid, or the alternative 2 cycles of tranexamic acid followed by 2 cycles of recombinant von Willebrand factor. And the reason we wanted to compare with tranexamic acid is it's the standard non-hormonal agent used for this. The order of these drugs was determined by randomization. So the recombinant von Willebrand factor is an intravenous hemostatic agent given at 40 units per kilogram IV on day 1 of a cycle. And tranexamic acid is an oral antifibrinolytic agent given in an oral dose of 1,300 milligrams 3 times daily on days 1 through 5. So group 1 received recombinant von Willebrand factor in cycles 1 and 2, followed by tranexamic acid in cycles 3 and 4, whereas group 2 received tranexamic acid in the first 2 cycles and recombinant von Willebrand factor in the last 2 cycles. Again, the order was determined by randomization, and 1 rescue dose of recombinant von Willebrand factor was allowed during a cycle in which our VWF was given. So in this 24-week crossover trial, we hypothesized that recombinant von Willebrand factor would be superior to tranexamic acid by an estimated 40-point reduction in HMB, and that it would be acceptable despite its IV route and cost. And we know the intervention. The primary endpoint was the pictorial blood assessment chart score. The secondary endpoints included safety and compliance as measured by diary, drug log, cycle severity score, cycle length, quality of life by 4 measures: the root amenorrhagia score, the CESD depression score, the SF36, and the CDC quality of life 14 score. We also did a cost analysis and a satisfaction survey for the von Willebrand factor. Our sample size was 60, which would provide a power of 84% and an error rate of 5%. So our primary endpoint was the pictorial blood assessment score, PBAC score, which quantifies heavy menstrual bleeding by its severity, summing the number and saturation of pads and tampons over a cycle, with a sensitivity of 86%, specificity of 89%, and has been validated as a measure of HMB. And it equates to a score of 100 PBAC is approximately 80 cc's of blood loss. So our selection criteria included inclusion of women 13 to 45 years of age, the standard age of menstruation, von Willebrand disease by a historic recombinant von Willebrand factor risk decedent cofactor of less than 0.50 international units per ml, and a history of HMB defined as a PBAC score greater than or equal to 100 in one of the last 2 cycles. In all of our patients, all had greater than or equal to 100 in both last cycles. And I might mention, we did not use GP1BM as an inclusion criteria because the test was not available at the time. We did do frozen sample assessment, which we'll talk about in a minute. And I might mention that the reason we did historic levels is because at the time of a study, there's a lot of stress. And we have shown in previous studies that the level can be falsely elevated at the time of a study. So we use historic levels. Exclusion criteria included hypothyroidism because it can simulate the menorrhagia that we see in von Willebrand disease, past thrombosis because of the warning, black label warning with tranexamic acid, renal disease because that's the route of excretion of tranexamic acid, and hormone oral contraceptives, again, because of the black label warning. In women who had iron deficiency, they had to have iron replacement, either PO or IV, before they could enroll on the trial. So here's our enrollment consort diagram. There were a total of 45 screened and a total of, after excluding 6 patients for ineligibility or withdrawal prior to randomization, there were a total of 39 randomized. And these were allocated to group 1, 17, and 19 were allocated to group 2. You can see that 3 withdrew prior to the first treatment cycle, but a total of 36 were analyzed. And the study stopped early based on slow enrollment and a conditional power analysis that suggested that less than 1% probability existed to conclude efficacy if we did get to 60. Now, this is almost 3/4, almost the end of the study. We had this analysis at the request of the NIH. So it was a very sobering day, but we do have good news. So here's the baseline characteristics of the subjects, and we're comparing group 1 with group 2. By age, they look very similar. By race, about 70% were Caucasian. By type of von Willebrand, the majority were type 1. We had 4 who had type 2 von Willebrand. By their risk decedent cofactor, very similar, 0.37 versus 0.40. By antigen, very similar. And on the frozen samples at the time of enrollment, the GP1BM was actually run, and it was 44 versus 45. You can see it's somewhat higher than the other levels. The PBAC score was very similar at baseline, 597 versus 483. And you can see there were a small percent who had a low ferritin or anemia. So here's our primary outcome. This is the measure of PBAC blood loss by treatment, and we're comparing tranexamic acid in orange with recombinant von Willebrand factor in turquoise. On the x-axis is the PBAC score, and on the y-axis is the cumulative distribution of the PBAC scores. And you can see that there was a significantly greater reduction in PBAC score in orange with tranexamic acid than recombinant von Willebrand factor. And we can compare the mean PBAC at the end of the study, which was 225 in those on tranexamic acid, and it was 272 in those who received recombinant von Willebrand factor. But both drugs significantly reduced the PBAC score from baseline. Now, we're going to look at the other primary and secondary outcomes. So in addition to the reduction in PBAC score, there was a significant reduction in flooding. 44% reduction with tranexamic acid, 60% with recombinant von Willebrand factor. And I might mention there was no difference in the trajectory of the fall in PBAC score between tranexamic and recombinant von Willebrand factor, nor was there a difference in those who required that single allowed rescue dose of von Willebrand factor. No difference in PBAC score outcome. Quality of life was similar between groups looking at RUTA and the CESD depression score, the SF-36, or the quality of life by CDC scale. There was no difference in healthcare utilization if you looked at days lost from work. Iron infusion, as you can see, 5 received that. Red cell transfusion, none received that. An emergency room visit for HMB, 2 of the tranexamic acid patients received that, and hospitalizations, none. In a satisfaction survey given to the women who, when they received recombinant von Willebrand factor, they rated in 86% that they were either satisfied as compared with their original treatment prior to the study, or more or much more satisfied with it. In terms of difficulty, in 86% said it was as same or no more difficult than their past treatment. And looking at the likelihood they would use it as compared with their old treatment, 70% suggested they were very likely or about the same likelihood as with their old drug to use VWF. Now, in terms of safety, and I want to point out that the adverse events here are reported as the number of events per cycle in which an event occurred. So there were 2 cycles per treatment per patient, totaling 72 cycles for tranexamic acid and 72 cycles for VWF. There were no serious adverse events. And the most of the events were mild bleeding that you might have expected. So there were no thromboses. Mucosal bleeding occurred in 4, injury or trauma bleeding in 1, and other types of bleeding such as hematoma. There were no allergic reactions, so the drugs were well tolerated. In a cost analysis comparing tranexamic acid with recombinant von Willebrand factor, tranexamic acid was significantly cheaper than recombinant von Willebrand factor. And we're looking at a cost per cycle, and here it's about $15 for tranexamic acid and over $1,000 for recombinant VWF. Other costs, including emergency department visits at about $21 per patient, or lost income at about 256 per patient did not differ by drug, that is between tranexamic acid or recombinant von Willebrand factor. So we concluded that tranexamic acid is cost saving as well as more effective than VWF in reducing heavy menstrual bleeding in von Willebrand disease. We also did von Willebrand factor next-gen sequencing. As you can see, there were 8 pathogenic variants, 8 who had pathogenic variants, 6 who had variants of uncertain significance, and 22 who had non-pathogenic variants or no variants. And what you see here is that there was a significantly lower von Willebrand factor antigen in those with pathogenic variants, 0.24, versus those with variants of uncertain significance, 0.45, or non-pathogenic variants, 0.41, significant 0.017 and 0.007. However, there was no association between the type of genetic sequence and PBAC score, either the baseline or after TA or after VWF. As you can see, there was no significant difference for any of those 3 groups. So we concluded that this is the first study that assessed the efficacy and safety of recombinant von Willebrand factor in HMB in those with von Willebrand disease as compared with the non-hormonal standard tranexamic acid. In this randomized crossover trial, in which each subject served as her own control, VWF was inferior to TA in reducing HMB by an absolute PBAC score. There were no differences in cycle severity or cycle length, and no improvement after a rescue dose of VWF. There were no differences in quality of life or healthcare utilization between treatment arms, but from an economic standpoint, tranexamic acid is cost-saving and more effective in reducing HMB than VWF. And this reduction in HMB with VWF adds to the evidence that is so minimal in the ASH, ISTH, and HFWFH international guidelines, which concluded low certainty regarding HMB treatment in VWD. I think there were some limitations that I'd want to mention. There's a large amount of variability in the PBAC score, making it difficult to compare. And there's also the issue of VWD diagnosed at screening because we used historical levels rather than current levels. The strengths of the study really have to do with the quality and completeness of the data that we collected, and really the study subjects who participated, without whom we really couldn't have done this study. I'm not sure if we have another slide here, but I would really want to focus on future directions, and that is, what could we be doing now? Some of the novel approaches to treat women with HMB, I think we saw absolutely no signals for thrombosis, and we have some additional data on women who are pregnant receiving these agents that don't have thrombosis. So there's really good argument to consider studies with estrogen, or even to combine VWF and TA in combination. Certainly other options would include considering the bispecific monoclonal antibody emicizumab, which has been used in many off-label situations, including von Willebrand disease. To consider the novel VWF factor VIII fusion protein, FE, which combines these 2 agents to promote the function of VWF and factor VIII. The silencing RNA that silences some of the VWD mutants in clinical studies, and other studies, other drugs that are in studies, such as the Aptamer BT200 that blocks VW clearance, and even the dual AAV VWF gene therapy. Many of these are really in clinical trials, and I would really want to say that we need to show that these have no teratogenic effects and that are safe in women as well prior to using them who are pregnant or on hormones. So I would really like to call out some people who really played incredible roles in this study. First, I don't even think I have her listed, Dr. Nahed Elkassar, who was our leader at NIH with all our conference calls and who kept saying we needed to do better. She pushed us to the end. She was a great help. I would also like to point out that Dr. Dan Bellissimo at Pitt did all of the molecular sequencing and analysis, a huge task. Dr. Ken Smith designed and helped us with our cost effectiveness analysis. And Dr. Scott Rothenberger was an amazing statistician who pulled out of his magic hat some findings that blew me away, and I think everyone else. And of course, I would be remiss if I didn't thank NHLBI for funding and also for Takeda Pharmaceuticals for making available Takeda, and finally all the patients who participated without whom we couldn't have done the studies, and all of you investigators, many of whom are on the call today, without whom we could not have done this study. So I think I'll stop there. Okay, so what is the first line of therapy by hematologists? And I don't think we have any music, and I won't sing, so you'll have a chance to answer. Oh, good. So tranexamic acid, you know, I have to tell you, in a survey of 16 HTCs with adult patients with HMB, it was actually oral contraceptives that was the first line. After that, it was tranexamic acid. But what I would also like to point out is that our VWF was the third choice, and only after everything else failed prior to this study. Okay, let's go to the second question. What proportion of HMB patients have iron deficiency anemia? Well, and you know, thank you all for those answers. I think it varies depending on the study that you see. It also depends on whether you screen for it, and if you look for ferritin, which is probably the best, the simplest and best option, we found in our studies that it's about 80%. We've also found that many times it is not screened for routinely. In our populations with women with HMB, that is a disservice to those ladies. We need to be screening. So next question. How long should oral iron be used before considering it a failure? And I know you're already thinking, she didn't tell us that. And actually, I'm going to tell you about a study, a talk from ASH by Dr. Auerbach, which was outstanding. And I will tell you why we're talking about it. Okay, what I would have said before I went to Dr. Auerbach's talk, that, oh, give it about 3 months. I couldn't agree more with what you all are saying, but what he said was 1 month. Why waste your time? If it didn't work in 1 month, you're wasting your time. It's not going to work. And actually, we're starting to do that in our clinic. This is very critical because these women are extraordinarily symptomatic from their iron deficiency, right? I mean, they're tired, they're wiped out. Our teenagers skip high school, skip class. You know, they're depressed, all the bad things that they could avoid by taking iron. In fact, one of my collaborators who's not a patient was telling me she had just gotten her second dose of IV iron, and I was so glad because I had to work with her to develop some slides for a talk, and she was really with it. And, you know, I mean, I think this is critical, guys. Let's help these ladies. Okay, I'm sorry. Next. How did tranexamic acid and RVWF compare in the VWD men trial? Yippee! So it's number one. Both drugs reduced the HMB by pBAC score, but neither was able to get it down to the normal range. And hence, we're really thinking about, should we be combining drugs or should we actually just allow patients to take the hormones that they're already taking and add these to them? And some women already do that despite black box warnings, which I am not so sure really need to be black box based on everything we're hearing about and some new data from a study Dr. Machin is running in pregnant women. So thank you for your participation. And please, I don't know, are you supposed to do this slide, Dr. Machin? I don't know what I'm supposed to do.
You're good. So at this time, we're going to proceed with the question and answer part of our program. As a reminder, all of you guys can submit your questions into the question box, and then we'll get them over here to Dr. Ragni. We do have one question right now in the box to start off with. So Dr. Ragni, how many patients ended up receiving a rescue dose of the recombinant von Willebrand factor? And did you notice any improvement in their pBAC?
Yeah, I think it was about 6 to 8. I'm sorry, I don't remember the exact number, but the truth of the matter is we actually did an analysis of the endpoint between those who did take a rescue dose and those who did not. Absolutely no difference in their pBAC score. Now, you could argue, hey, that pBAC score doesn't tell us anything. Well, right now, we don't have a better score. And they didn't acknowledge that it was all that much better after that rescue dose. However, we made it available for clinical, medical reasons, health reasons, so that they would be comfortable taking the drug.
All right. And then while we wait for some more questions to get into the chat box, I have a question for you. And that would be, and you kind of hinted at this, one of the struggles that we have as far as like measuring bleeding outcomes. And so like in this particular sense, it's the pBAC. I think we can all appreciate when we look at those charts of yours that there's huge plus or minuses on all of the ranges. And that I think makes it exceptionally difficult to demonstrate differences and even improvements. So I'd love to hear your thoughts about that, or maybe what we should be thinking about for future outcome measures.
Well, I think that is, maybe that's the crux of the matter. I mean, that is really critical. It's such a variable outcome and such a wide range of what our patients had. In fact, we used that 40-point score because percent reduction just didn't make sense. How do you normalize this across a group? Very, very difficult. We actually modeled after what Vanessa Byams and our good colleague up at the University of Rochester, Dr. Peter Quides did, and used this 40-point difference and modeled it actually after that. But I think that it's still quite hard. And one of the things that I think is really a potential study and a potential way to get at this is to say, come on, look at ITP. They have that wonderful 4T score. How come we don't have a 4 HMB score? I think we could do it. That's a study that, I mean, the way they figured that out, my good friend Adam Suker, is he just looked at a large database and did a regression analysis on the variables and said, what are the top 4 variables, and incorporated them based on the proportion of how they influence the outcome to make a simple score, that 4T score. So, I mean, the question would really be, what are the top biomarkers? And Dr. Machin, you're the one who has the expertise in this area, right? I mean, you know, you designed a K award looking at iron, ferritin, VWF, propeptide, GP1BM, whatever, and how might we do this? And should we use a large database to try to get at this? What are your thoughts? Am I allowed to ask you a question?
Well, we have a lot of other questions now, but yeah, I would agree. I think in going through this and with a lot of this research, it's asking for some better ways for us to measure this, because it is a struggle to have people visually inspecting their blood loss. Okay, so here's one that I got for you too. It says, you mentioned some differences in von Willebrand levels in participants with known pathogenic mutations versus variants of unknown significance. Did you notice any difference in patients with low VWF related to type O blood, or was that something that you looked at?
Related to type O
blood.
Oh, type O blood. You know, interestingly, blood types don't seem to influence this at all. And that's been the case in many other studies. So great question, no.
All right, I got another one for you. Was there a difference in the age of groups that responded to TXA versus the RVWF? Did younger patients respond better to TXA versus older women?
I wish I could tell you there was something there, but no, absolutely no difference at all.
All right, so I'm also interested in your answer on this very much. In which VWD patient would you anticipate something like emicizumab would be considered?
You know, that's a great question. I really think that actually starts a conversation about how we do our management with the patient. We need to talk with them. Patients should be at the table when we design studies so that we hear what they are willing to do and what they're not willing to do and how we can work best with them. You know, when do you use emicizumab? I would be interested in what they say, but if this is a single sub-Q dose on day 1 of your cycle, how hard can it be? And very few side effects. You know, I think we ought to collect data. I'm a proponent of doing studies because studies are the only way to truly get at what is the better treatment. However, I'm also a proponent of talking with patients about what they want to take. I mean, if we have a study that says both drugs reduce the HMB, then we should be sitting down with them and saying, you know, here's some things we could use. What do you think about RVWF? Nah, I don't want to use IVs. I faint when I see an IV, and I'm not doing that. So there's the answer there. Would you consider a sub-Q drug? I mean, in other words, you want to get some baseline data. If we could show in a pilot study or with some collected data around the country, people have done this. How many women taking sub-Q emicizumab have had improvement in their cycles? In fact, when we started this study, we had to show NIH that we had data on RVWF in HMB. Now, where the heck would we have gotten that? Well, I'll tell you where we got it. 6 patients who were women, thank you, on the original RVWF study, phase 3 study, took it for HMB and had a marked improvement. That was our baseline data, N equals 6 patients. So I think we need to collect data, no matter how small, that gives us some signal that there is an improvement, and then design studies so that we're not also wasting people's time. If we do a study comparing two drugs, why not use a platform design where you start with 10, 15, 20 patients, and when you start seeing a significant difference, then go on to the next drug in the comparison if such a difference exists. And it may be that we'll have a variety of drugs to which patients could respond, or that there will be a standout winner, but that doesn't preclude us from talking with our patients about these are some of the drugs with which you might see some effect. So I think it's a patient-doctor discussion, doctor-patient discussion, and we really need to hear what they think and involve them in designing this. And if I could, I would put a plug in for doing multi-center studies on a national basis, sort of the concept here with the National Research Blueprint with the NBDF, the old NHF, because what we need to do is hear what the patients think, involve that in how we design and how we participate in trials. And I think these are critical things that we're learning, and we need to really listen.
I think to sort of piggyback onto what you're talking about there, I do have a question and an observation. So one of the things that has stood out to me as being at the Hemophilia Center of Western Pennsylvania, where a lot of these subjects were at, the vast majority of them who I see in clinic have continued on our VWF. Yeah, so, and they tell me that's because they feel that it does better for them. Most of them have learned how to self-infuse so they can do that at home. So I'm constantly surprised when I look at the results from this, particularly for maybe the outcome, like the quality of life measures. Do you think that there was some other way maybe we should have asked that? Because to me, these people have stayed on their therapy, and that must speak to something.
Well, you know what I think that does speak to? That a relative 50% decline in your HMB, while it doesn't get to 100, is such an improvement for these ladies that they're sticking on the drug. I mean, that is my sense. And look, the same thing happened with TA. Women who like TA wouldn't have a thing to do with RVWF. Notice that it helps them with their HMB. I think that's part of it, that a 50% decline. In fact, I haven't done the study to look at what is an adequate response for 20 women. What is their HMB and what is their perception of response? Now, you know, something else that was a little weird was we didn't really see a change in quality of life. So is it that their quality of life wasn't so bad that it didn't make a difference, and yet their quality of life with regard to, you know, tampons and how much bleeding they're having was significantly improved enough that they wanted to continue the drug? I mean, I think that might be the difference. I don't know.
Yeah, it just always surprised me. And I do have another question from the audience for you. So was there any correlation between ferritin levels and patients' responses?
Nope, not at all. And don't forget, part of that we got rid of because we required, for health reasons, for medical care, that patients who enrolled on the study had to have IV or PO iron before they started this study. It would have been unethical to take somebody on who felt so crappy and was so low in ferritin, but there was no relationship. And in fact, if you saw, there were only 3 people who had very, very low ferritins. So I don't think that was an issue at all.
All right. So I would encourage everyone out there, if you have any remaining questions, to get them in. So I have one more question for you from me, Dr. Ragni.
Oh,
so,
okay.
And you've already kind of commented on this. When we looked at who these patients are, they sort of feel like perhaps more typically like mild or low VWF type patients. So when you think about what this research means to you for this study population, do you think that impacted our outcome here? Would you have expected a more severe group maybe to benefit more from von Willebrand directed therapy?
Well, actually, I think there's a chance that we should consider doing it in a type 2 and type 3 group. I think we might get a much more profound response, but here's the problem. Most of our type 3s are already taking hormones and wouldn't stop it for the world. Most of them require RVWF for every little everyday things once every couple weeks. When we designed this study, our concern was that we would mask our outcome because they were already taking RVWF. But I would argue on a larger study where everyone had type 3, you give the drugs, you might see a difference between those who had a chance to take RVWF with their cycle versus those who took TA on top of and despite estrogens or VWF. But I truly do not know. What I really think this study shows us is that there may be multiple ways to work to reduce HMB. Does it matter that one's better than the other slightly and that neither really got there? I don't know. And how far does it need to go back to 100, which has been established as the norm for these women? I don't know. I think many people would say, just as the men with hemophilia, I want to have lack of fear, flying or whatever it is you're doing because your levels are good enough. I want a level of 50% or I'm just not playing the game. And these women may very well say, I want a P-back of 100 or forget your drugs. And that's a good, goal. Is it critical to get to that level? I don't know. I think your point about what you see in clinic is really critical. That if you can reduce it to a point that women feel they're getting somewhere with their symptoms, that's great. And the other thing I would do is ask our OBGYN colleagues, and by the way, I forgot to recognize that it was Dr. Andy James who was our trial expert, that we went to her with OBGYN questions during the study. And thank you, Andy. I'm sorry you're probably here and I forgot to mention you, but you were critical. And I would even argue that we should be collaborating with our OBGYN colleagues to get a better handle on what is the meaning of HMB and are there better ways to do it? And what do they think? What is their experience in that area? And how could we together design better outcomes and look at better approaches to the problem? I really think we're missing the boat if we're not working with them.
All right, I have another audience question for you, and it is that as the duration of the menstrual cycle is much longer than the half-life of RVWF, would more doses of RVWF per cycle be worth testing? For example, every other day or 3 doses, etc.
Well, very interestingly, we talked a lot about that. And if you recognize that if you could stop the bleeding with 1 or 2 doses, you probably wouldn't need more doses. I mean, some women do use them. I am not convinced that that makes a difference. I mean, what's your sense in the clinic? No one has asked me for day 3 to day 5 to take VWF once they've used it for the first few days. I mean, you have more experience. Go ahead.
For the group that I was referring to, who was on this study and then has subsequently continued on RVWF, I haven't had anybody ask for an escalation of therapy. So my crew is still just getting 1 dose, but I haven't also heard any problems yet.
Although, we could argue that the place to test that question would be the type 3s or the severe type 2s and see if they felt after 2 doses or 1 dose or however you wanted to try it, allowing them to take what they thought they needed. But many women notice a reduction after the first 2 to 3 days, and our ladies did. Is that because they're milder? Possibly. I think we need to test that to figure it out, but it's a great question, whoever asked it.
All right. Okay, I got 1 more for us. So in men, we use reduction of annualized bleeding rate as a marker for drug effectiveness. Should HMB be used as an ABR marker for trials that include women?
Yeah, I've thought about that as well. But until we get rid of all the variability, and we can argue, because you see, annualized bleed rate is, did you have a bleed or didn't you? We're dealing with, we're having a bleed, guys. How well did we stop it? And that's a different question. If we could get better biomarkers that could measure it than HMB, it might be something to look at as like a change over a cycle. So, you know, a delta 4T score, I mean, a delta 4 HMB score. I don't know what that is, but I do think we ought to work on that because I think it's a critical question until we could say it was an ABR or an HMBR.
Gets back to that P-back troubles with
It
the
gets,
level of variability, intercycle variability there, you know?
yeah, yep, it does.
Well, I think that's all of the questions that we have right now. So we want to, thank everybody for joining us for the discussion and the presentation. Dr. Ragni, on behalf of FWGBD, we would like to invite you and everybody else on this call to attend the biannual conference to take place in September 13th to 15th, 2024 in Long Beach, California. Registration will be open soon, so please stay tuned for more. And the foundation is pleased to provide this program at no cost to attendees. Participants will receive an evaluation following this program in your registration email in about an hour, along with a link to claim your continuing education certificate. The recording will also be made available by the end of the week, and all registrants will be informed once this is available. Thank you for your attendance today, and we look forward to your future participation in SWGBD program. Mm-hmm.